So thank you very much, and I'd like to welcome everybody, and thank you very much for your introduction, and also for inviting me to this talk here. This talk will a little bit giving the link between what we have heard earlier this morning, and even heard about old and new technologies to apply in the new situation, and what we will hear in the next talks, which will tell us about the voices on the field. I tell you about the successful transfer of the lessons learned and other projects and how to successfully apply it on a new population, on a new region, and this always needs adaptation and modification, as you have heard before, and this is also, of course, a voice from the field. It's about Stop Malaria. It's a project of Rotarians from District 1860, together with the Rotaractors in Kenya and Germany, together with the Kenyan NGO. We are working together since many years, and this is funded by the German government. It's a project with about $400 budget. 3/4 come from the German government. About $100,000 were collected by the German Rotarians, and we didn't do it as a global grant, but we did it with the German government, because for every dollar you collect as a Rotarian, the German government in this kind of project gives you $3 more, so that you have a better donation level compared to what you can achieve with a global grant at this moment. This project is based on the concept of the first ever D of programs of scale, as you heard before, the 2 million from Rotary International and 4 more millions from other partners, implemented in 2021 by the partners from Malaria-Free Zambia you have heard about, and you will hear some more by Eric and Martha in the next talks. The objectives of our project are nearly the same. We want to achieve a marked reduction of malaria burden of disease in vulnerable groups within 3 years. And more or at least the same importance is that strengthening of the local healthcare system in terms of sustainability. Our concept is fully in line with the Kenyan National Anti-Malaria Strategy, and we did some adaptations due to our local conditions in rural Western Kenya. And I will give you a talk about these kind of adaptations and why they are necessary to be successful. But allow me one remark how it comes to this project, and this is about the Rotary Foundation cadre of technical advisors. Allow me a little bit of advertisement for this. These are your project planning expert. And I had the opportunity to do the interim visit to the Programs of Scale project in Zambia 2022. And that gives me the chance to learn the lessons over there, to see what lessons they have learned. I learned a lot of lessons, and it gives me the chance to transfer this to my own project, which I created after I have seen what they have done there. I think this is what Rotary really wants, that you have got the programs of scale, and this is transferred to other projects over there because of people see what's happening there. And always keep in mind that there are the technical coordinators. These are voluntary Rotary members with a professional expertise in Rotary areas of focus and also financial auditing. We have got 500 advisors worldwide, 75 countries, and they speak 80 languages. So whenever you have a project in your district and you need advice, try to go back to the technical advisors. You will find someone who can help you to implement, to design, and to sharpen your project. So back to Stop Malaria. Stop Malaria is taking place in the project region in Rarieda. This is near the Lake Victoria, near to the Uganda border in western rural Kenya. In this area, we with other Rotarians from District 1860 are working together since nearly 15 years, together with a very trustful, powerful NGO Rafiki over there. And in this time, we implemented projects with a total volume of 1.8 million US dollar up to now, including 5 TRF global grants before we implemented Stop Malaria. What about malaria in this area over there? We are in Siaya County, and this is among the 5 counties in Kenya with the highest burden of malaria disease. The reasons are the climate, obviously, and also, as we heard before, the socio-economic structures. This is poverty, it's a high rate of HIV, and a relatively weak healthcare system. And the Rarida region, as a sub-county of Siaya, is particularly affected by these factors. What are the objectives of Stop Malaria? We want to reduce the malaria burden of disease. Our goal was 80% in the most vulnerable groups of children more than 5 years and pregnant women, and especially with the key indicators of mortality, severe disease cases, and referrals to the hospital, and maybe incidents. So community-based prevention and treatment measures within 3 years, and we targeted the so-called beach communities along the Lake Victoria. We have about 12,000 direct beneficiaries, which prevented malaria cases, and we have a population of 48,000 indirectly beneficiaries. These are the population of this area. What are the project's 3 key elements? This is on the basic ICCM. This is done by community health volunteers together with the local level 1 and 2 health facilities. So this is the basic health care over there. The second element is distinct and ongoing community-based education, promotion, and mobilization on malaria prevention. And the third key element is coordinating all local stakeholders involved in the fight against malaria to aim at the same goal. What kind of adaptations did we do compared to the Zambia project in order to successfully scale this kind of project on our area and our population? You know, scaling in Zambia means that you start with a copper belt and you are growing and make it bigger and go up to the programs of scale, and now you're more scaling, go up to RHCC. And this kind of scaling means transferring a proven concept like it was in Zambia to another area and to another population. Whenever you do this, I'm convinced that you have to adapt. You cannot simply take the things up to another population or other region. You have hardly do a new needs assessment regarding your situation on the grassroots and adapt. What did we do adapt? Our CHVs were mainly existing. So we retrained them, motivate and provide a small stipend because at the time we started with the project, there was no stipend by the government. Now this is sustainable. The government stepped in and they have a stipend from the government. So we can step back with this. This is optimum. We provide a buffer stock to secure supply of ACTs and RDTs. I learned in Zambia that sometimes that's a problem over there, and also in Kenya. The government is distributing RDTs and ACTs, but you cannot always rely on that. So we decided to do a buffer stock, the same we did for the nets. We did promote vaccination of children smaller than 2 years. Our area was one of the pilot areas of vaccination of children. And the vaccine is always on a regular basis by the government or Gavi or WHO, whoever is behind that, available at this moment. So we promote hardly to do the vaccination. We worked with schools since many, many years, so we pushed on integrating the schools in the malaria campaigns. And more the last years we integrated Rotaractors as we found a Rotaract club on this ground, and we add this. And we were also adding IRS in the smaller scale. We are doing 2 campaigns but limited number of households, not to all of our projects. What have the community health volunteers to do? So they should distribute and secure correct use of mosquito nets as far as necessary. For the pregnant women, they motivate for preventive treatment, at least 3 doses. They should secure immediate on-site testing with the malaria tests they get in suspected cases. And if these cases turned out positive, they directly deliver on the household level the appropriate on-site treatment so that the medication comes to the patient and not the patient has to come to the health facility center. They should ensure secure the prompt referral of critical cases to the local health facilities. And regarding vaccination, they promote regular vaccination against malaria for the small children. What did we achieve? On the left-hand side, you see the baseline, which is between 2020 and 2022. And we have the data for 2024 in our area. We achieved that the correct usage rate of the nets is above 85% now. We have nearly 100% of the cases proper ICCM care by community health promoters now. The malaria knowledge in population becomes more and more sufficient. We did surveys and M&E all the time in interim. And we are nearly, we have a sufficient knowledge, about 75% now. The children smaller than 2 years are completely vaccinated, get all shots, and 65% now. And we have 85% partial vaccinated children smaller than 2 years. Our campaigns for advocacy for sustainable supply of malaria commodities were successful, that we have stock out gaps smaller than 10% of the days in a quarter now, and we came from more than 30% on the level of the CHPs. And if we look at the malaria incidence for the children smaller than 5 years, we came roughly from about 52%, and we are now by 22% in 2024. And I hope that we will get a little bit better until the end of our project in October 2025. And we look at incidence in pregnant women, we came from 38%, and we now are about 15%, and also hope to get a little bit better. If you look finally at severe malaria cases with the hospitalization, we could reduce this by 66% in the children smaller than 5 years, and by roughly about 50% in the pregnant women. We had zero malaria mortality cases in children smaller than 5 years and pregnant women in 2024. Unfortunately, we had one fatal case in a small children 4 years old in January of 2025. So we are not always achieving 100%, of course. So I think that's the final slide, and I hope I was able to explain how it's possible if you adapt systems which have been proven successful in other communities and in other surroundings, and you carefully look at your situation on your grassroots level and do the necessary adaptations, that you will be able to create successful projects really doing an impact. Thank you very much.
I think we don't have time for questions for this panel, but I would encourage any of you that want to ask Marcy, Pranav, and Axel questions to follow up during lunch or a break or that kind of thing. But thank you very much for your presentations. It was very informative. Appreciate it.